Okay, well, it looks like everyone has sort of joined in, but I did want to welcome everyone to today's webinar. This is titled Behind the Scenes with TissueCypher Barrett's Esophagus, Getting to Know the Technology Driving Better Risk Stratification in Barrett's Patients. My name is Jay Morris, and I am the manager of the GI Medical Affairs team at Castle, and I'll be your host for this evening. From that, I would like to introduce our speaker. So, Dr. Rebecca Critchley-Thorne serves as our Vice President of Research and Development, Spatialomics and GI at Castle Biosciences. Dr. Critchley-Thorne led the development of TissueCypher and computational pathology platform, as well as the TissueCypher Barrett's Esophagus test and the clinical studies supporting its use. She completed her postdoctoral fellow training at Stanford University, where she focused on highly multiplexed analysis of biomarkers to understand mechanisms of immune dysfunction in various cancer types. She also completed her doctoral work in cancer immunotherapy at the Imperial College and Cancer Research UK in London. And Dr. Critchley-Thorne is the author of many medical and scientific publications. She's been a principal investigator on NIH-funded research studies and an inventor of several of Castle Biosciences patents. For tonight's webinar, Rebecca's presentation has been recorded to ensure the highest quality for the audience. Please feel free to start loading questions into the question and answer module as you think of them. And then once the presentation is completed, we will move to a live Q&A session for around 10 minutes or the remainder of the time, and maybe stay a little after. So without further ado, let's start the presentation.
My name is Rebecca Critchley-Thorne. I'm VP R&D for Spatialomics and GI at Castle Biosciences. Today's presentation will focus on the TissueCypher Barrett's Esophagus test, which independently predicts esophageal cancer development in patients with Barrett's esophagus. The TissueCypher Barrett's Esophagus test addresses multiple clinical needs in the management of patients with Barrett's esophagus. Barrett's is the only known precursor to esophageal adenocarcinoma, which has a 5-year survival rate of only 21%. Guidelines do recommend endoscopic surveillance with biopsies for patients with Barrett's, and the goal of endoscopic surveillance in Barrett's is to detect dysplasia and esophageal adenocarcinoma at early treatable stages. Pathology diagnosis and clinical factors do have some predictive value, and effective endoscopic eradication therapy is available. However, despite extensive surveillance programs, there's been no reduction in the incidence of esophageal adenocarcinoma and no improvement in survival rates for decades. It can be very challenging for physicians to identify which patients in their population are at high risk for progression and will benefit from escalation of care, and also to identify patients who are at low risk for progression. Precision medicine tools are needed to risk stratify patients with Barrett's to enable improved risk-aligned management. Up to 86% of patients in surveillance for Barrett's are diagnosed with non-dysplastic Barrett's. And this diagnosis carries a low risk of progression overall. The progression rate is 0.63% per year in non-dysplastic Barrett's. However, due to the size of this population, it's estimated that 50% of annual progressors are initially diagnosed as non-dysplastic. Low-grade dysplasia is associated with a higher risk of progression. However, there's significant inter-observer variability in the diagnosis of low-grade. Up to 85% of low-grade dysplasia patients are downgraded upon expert pathology review. Missed prevalent disease is also a challenge in the management of Barrett's. 25% of high-grade dysplasias and cancer diagnoses occur within 1 year of the initial endoscopy. Those high-grade dysplasias and cancers are likely there at the patient's first endoscopy, but are missed, and that delays their diagnosis and proper treatment. These statistics highlight the need for additional risk stratification tools to identify more progressors early to reduce the incidence of esophageal cancer. TissueCypher was developed with the goal of unlocking the molecular and cellular signatures of progression. There are multiple signaling pathways that are involved in the development of esophageal adenocarcinoma. The TissueCypher technology objectively quantifies biomarkers of multiple pathways in the context of cellular and tissue structures. The image analysis techniques used by TissueCypher enable separation of the features that matter from the noise. And we can use this information to predict which patients are heading from Barrett's esophagus to esophageal cancer. TissueCypher uses a spatialomics approach, and there are 4 key components. The first is multiplexed fluorescence labeling and imaging of biomarkers on tissue slides. TissueCypher uses computational pathology to detect cellular and tissue structures. The computational pathology software also enables extraction of features. Once features have been extracted, they can be evaluated by model building, and those models need to undergo extensive clinical validation. I'll go through each of these 4 components in more detail, starting with the multiplex labeling and imaging. 3 protein-based biomarkers plus nuclei can be labeled on a single slide. These slides are standard formalin-fixed, paraffin-embedded tissue slides. Once labeled, these slides can be imaged by whole-slide fluorescence scanning. 4 channels of registered image data are collected from each slide. And I'll go through some example images of labeled slides here. In each of these examples, the nuclei will be labeled in blue. P16 is shown in green here. P16 is involved in cell cycle control. It can be lost in the development of esophageal cancer through mutation or methylation. P16 in this example is expressed in some of the glandular epithelium and lost in other areas, indicating increased risk of progression. P53 is also evaluated by the TissueCypher test. It's shown in yellow here. Various mutations can lead to aberrant P53, including accumulation of P53 protein, as shown in this example, as well as P53 loss. And this aberrant P53 profile has been associated with increased risk of progression. AMACR is involved in lipid biometabolism. It's shown in red here. Overexpression of AMACR in the epithelial cells within Barrett's biopsies has been associated with increased risk of progression. HER2/neu is another of the TissueCypher biomarkers. It's shown in green here, and it's measured in conjunction with cytokeratin 20, which is shown in red. HER2/neu is an oncogene, and when amplified, it indicates significantly increased risk of progression. And this occurs in a subset of the patients who develop esophageal cancer. Stromal processes are also evaluated by TissueCypher. Chronic inflammation is an early driver of malignant progression. Macrophages are shown in green here, mostly restricted to the lamina propria. They can be involved in malignant progression by creating an inflammatory environment. COX-2 is also measured. It's a marker of inflammation. It can be measured in the epithelial cells. It can also be measured in conjunction with the macrophages because it can indicate their phenotype, and an M2 phenotype of macrophages promotes malignant transformation. HIF-1 is an additional stromal marker that's measured by TissueCypher. It's shown in green here, and the heavy infiltration by HIF-1 expressing cells in the lamina propria of Barrett's biopsies indicates that angiogenesis is occurring, which supports malignant progression. And the final biomarker that's assessed by TissueCypher is CD45RO. This is a marker of memory lymphocytes. And in this example, there's heavy infiltration of the lamina propria by these memory lymphocytes, which play a role in the malignant progression of Barrett's to esophageal cancer. So collectively, this panel of biomarkers evaluates multiple pathways of malignant progression and also assesses the chronic inflammation and role of the immune system in the development of esophageal cancer. Once images have been acquired, they are analyzed by the TissueCypher computational pathology software. And the first step in that process is the detection of cellular and tissue structures. This is an example of a Barrett's biopsy. The first thing the software does is find all of the small pinch biopsies that are present on tissue slides. It will then identify nuclei as individual objects. Measurements can then be taken on each individual nucleus, such as size and shape and amount of DNA. The spatial location of each nucleus is recorded so that spatial relationships can be calculated as well. The nuclei are then used to estimate the cell areas. Nuclei are subtracted from the cells to identify the cytoplasmic areas. The software also identifies the epithelium, epithelial nuclei, metaplastic epithelium, and the software also extracts the stroma from the epithelial areas so that measurements can be specifically made within the stroma. And the purpose of this series of segmentation tasks is to detect cellular and tissue structures such that biomarkers can be measured in their appropriate context. Once cellular and tissue structures have been detected, the next step is extraction of features. Features are quantitative measures of biomarkers, which can be protein-based biomarkers and also nuclear morphology. When the test was developed, 14 candidate protein biomarkers were evaluated, and the software extracts 7 cellular and tissue structures. These parameters can be combined to extract approximately 200,000 primary features. Examples of primary features are the mean intensity of p53 in nuclei of metaplastic epithelial cells, or the amount of DNA in epithelial nuclei. These primary features can be further combined to produce secondary features. It's possible to produce over 10 million secondary features by combining primary features in various ways. Those combinations include ratios of 2 biomarkers to each other, or ratios of a biomarker in different subcellular compartments or different tissue compartments. Secondary features also include co-expressions, such as co-expression of COX-2 in CD68. These features also include measurements in gated populations. It's possible to drill down on populations of cells that have abnormalities in multiple biomarkers and then take further measurements on the gated cells. The secondary features also include microenvironment type features that measure multiple high-risk features in small hotspots within the tissue. Examples include clustering of HIF-1 alpha positive cells in the stroma, indicating angiogenesis, and nuclear area in cells with aberrant p53 and p16. So while it's possible to produce over 10 million features from a single slide, when we developed the TissueCypher Barrett's esophagus test, we extracted over 13,000 candidate Barrett's associated features, and those were further evaluated in the next step, which is model building. In order to develop the TissueCypher Barrett's esophagus test, we built a training cohort. This consisted of 41 incident progressors and 142 non-progressors. Feature extraction was used to extract 13,538 features for each patient tissue sample. Various machine learning methods were applied to build predictive models, and the performance of those predictive models was then evaluated. The top performing model was based on 15 features derived from 9 biomarkers and nuclei. All parameters of that model were locked and then tested in a separate validation cohort, which consisted of 38 incident progressors and 145 non-progressors. And when the test was evaluated in that separate validation cohort, patients who scored TissueCypher high risk were 9.4 times more likely to progress to high-grade dysplasia or esophageal adenocarcinoma than patients who scored low risk. There's now robust clinical validation and utility evidence supporting TissueCypher. 9 studies have been published demonstrating the clinical validity and utility of the test. These studies have consistently shown that TissueCypher outperforms both histology and segment length as predictors of progression in Barrett's patients. The TissueCypher test is one of only 12 tests to receive advanced diagnostic laboratory status from Medicare. A recent pooled analysis of multiple clinical validation studies demonstrated that TissueCypher is the strongest independent predictor of progression. First, the predictive performance of the original pathology diagnosis was evaluated. And this was evaluated in 699 patients. It included non-dysplastic, indefinite, and low-grade, as well as incident progressors and prevalent cases and non-progressor patients. As you can see in the Kaplan-Meier on the left here, the original pathology diagnosis did not provide any significant risk stratification. Patients with low-grade dysplasia, indefinite for dysplasia, and non-dysplastic patients progressed at similar rates during follow-up. By contrast, TissueCypher provided significant risk stratification in this population of patients. Both the intermediate risk and the high-risk classes of patients were at significantly increased risk of progression. Patients who scored high risk were 7.8 times more likely to develop high-grade dysplasia or cancer when compared to patients who scored low risk. TissueCypher is commercially available and integrates easily into your practice. The test provides an easy-to-interpret risk score. The test is indicated for patients with non-dysplastic Barrett's, indefinite for dysplasia, and low-grade dysplasia. A high-risk score by TissueCypher may enable increased surveillance or early intervention, which are both effective strategies to prevent development of esophageal cancer. A low-risk score may minimize overtreatment and support extension of surveillance intervals to guideline recommendations. And it's important to note that patients with scores greater than 5.9 have a risk that is greater than confirmed low-grade dysplasia and may benefit from similar management to patients with low-grade. And a recent clinical practice update from the AGA included the following best practice statement: tissue systems pathology-based prediction assay may be utilized for risk stratification of patients with non-dysplastic Barrett's. I'll move on now to talk about how TissueCypher can be used to improve the management of Barrett's esophagus. Multiple studies have now shown that TissueCypher guided management has significant utility with the potential to improve health outcomes. A decision impact study by Geisinger showed that the TissueCypher Barrett's esophagus test impacts clinical decisions in the management of patients with Barrett's. A randomized controlled trial of clinical utility by Cure demonstrated that introducing TissueCypher increases adherence to guidelines in the management of patients with Barrett's. And a patient management simulation study demonstrated that TissueCypher can standardize management decisions with the potential to improve health outcomes for Barrett's esophagus patients. A decision impact study by physicians at Geisinger Health System demonstrated that TissueCypher impacted clinical management for 55% of Barrett's patients. In 21.7% of patients, TissueCypher high-risk scores guided upstaging of management, resulting in endoscopic eradication therapy or shorter interval surveillance. In 33.3% of patients, TissueCypher low-risk scores guided downstaging of management, leading to surveillance rather than endoscopic eradication therapy. The study demonstrated that TissueCypher had significant clinical utility to improve the management of Barrett's patients, including escalation of care for patients who scored high risk and de-escalation of care for patients who scored low risk. A recent study by Cure Healthcare demonstrated that physicians who adopted TissueCypher more accurately assessed the patient's risk. This study was a randomized controlled trial, and it was performed to determine the impact of TissueCypher on the quality of management for patients with Barrett's. 259 GI physicians participated in this study and made management decisions for patients with non-dysplastic Barrett's, indefinite for dysplasia, and low-grade dysplasia. This study found that physicians who adopted TissueCypher were significantly more likely to accurately assess a patient's risk of progression and also to recommend endoscopic eradication therapy when it was appropriate. Physicians who did not adopt TissueCypher performed similarly to the control group who did not have TissueCypher results available to them. This study provided further evidence to support the clinical utility of TissueCypher to improve risk-aligned management of patients with Barrett's esophagus. A study by investigators at Amsterdam University Medical Center demonstrated that TissueCypher can increase the likelihood of appropriate management decisions for patients with Barrett's esophagus. The clinical utility of TissueCypher was simulated in 154 patients with known clinical outcomes. These patients also had diagnoses from 30 pathologists. Management decisions were simulated based on the standard of care and also based on TissueCypher used in conjunction with the standard of care. TissueCypher significantly improved the management of patients with Barrett's esophagus. There was a significant increase in the percentage of patients receiving appropriate management when TissueCypher was used to guide care compared to the standard of care alone. Significant increases in appropriate management were seen in patients who progressed to high-grade dysplasia or cancer, and also in patients with outcome data showing no progression. This decision simulation study showed that TissueCypher guided management of Barrett's patients improves the likelihood of appropriate management. The test also can increase consistency by reducing the impact of variable pathology review. The test may be used to standardize management and improve health outcomes. The test increased the likelihood of appropriate management such that there was an increase of the percentage of progressors receiving endoscopic eradication therapy. There was also a reduction in the percentage of progressors being managed by 3 to 5 year surveillance. This can lead to a reduction in the incidence and mortality of esophageal cancer. The study also showed that use of TissueCypher to guide care can increase the percentage of non-progressors who are managed by surveillance only. And this can reduce the unnecessary use of endoscopic eradication therapy and also reduce the overuse of endoscopic surveillance. In summary, the TissueCypher Barrett's esophagus test has been extensively validated to provide objective risk stratification for patients with Barrett's. Its clinical utility has also been demonstrated, indicating that the test can enable risk-aligned management, including escalation of care for patients who score high risk and de-escalation of care for patients who score low risk. Thank you for your time.
So thank you, Rebecca, for that wonderful presentation. We do have a few questions that came in during the session in the question and answer box. The first one was really focused on P53, and they wanted to know, how would you compare insights offered by TissueCypher with an assay that looks only at P53 expression?
So P53 is an important predictor of progression in Barrett's. There is a lot of literature supporting its role as a biomarker. And so TissueCypher does measure P53. It's one of the 9 protein-based biomarkers assessed by the test. The test does assess 8 additional protein-based biomarkers such that multiple pathways of malignant progression are assessed, not just P53. And that includes other biomarkers such as HER2 and P16, as well as a collection of immune biomarkers and also an angiogenesis biomarker. So TissueCypher is assessing multiple factors that can indicate a patient is going to progress to esophageal adenocarcinoma. The test also measures multiple aspects of nuclear morphology that can indicate a patient is on the way to progression.
Thank you. So another question is, how was the decision made to determine the cut points between high risk, intermediate, and low risk in the test?
So the cut points were set in the training phase. As described in the presentation, we used a training set of 183 patients with Barrett's. These patients were a diverse set from 4 institutions and included patients who progressed to high-grade dysplasia or cancer and patients with outcome data showing no progression. And so that robust training set was used to select cut points to classify the majority of non-progressors as low risk and to classify the majority of progressors as high risk. And there was input from multiple practicing gastroenterologists who were co-investigators on that study as well to make sure that we were selecting clinically impactful cut points for the test. And those cut points were locked in that training phase, and those are part of the locked set of parameters that form the clinical test.
Thank you. So another question was, how does TissueCypher perform in regards to, typically thought of as, clinically low risk patients, such as women, maybe short segment patients of those variety?
So multiple studies have now shown that TissueCypher provides independent risk stratification. And by that, I mean it's independent of standard clinical and pathology factors. A recent study was published this year that was a pooled analysis of 5 completed clinical validation studies. And that study specifically looked at how TissueCypher performed in clinically lower risk subsets, such as women, patients with non-dysplastic Barrett's, as well as patients with short segment. And the test provided similar risk stratification in those clinically lower risk subsets when compared to its risk stratification in higher risk subsets, such as patients with indefinite for dysplasia or low grade, and also men and patients with long segment Barrett's. So the test is providing risk stratification across the population of Barrett's patients independently of clinical and pathology factors.
Thanks. So we have a question from Dr. Poppers. He wanted to know or comment, I guess, on the relative utility for decision-making in reference to surveillance versus EET and upgrade and downgrading in an academic setting. I know we spoke about the Geisinger study, and he added, with expert GI pathologists and advanced imaging EET capability versus smaller centers. So has it been looked at in some of these more academic, larger referral centers associated with major universities? Hopefully I didn't butcher that too much, Dr. Poppers.
So Geisinger did publish a study describing the impact of TissueCypher on their decision-making. And the 2 physicians that participated in that study were interventional endoscopists. They were typically seeing patients referred to them to consider treatment. And they used TissueCypher in patients with low-grade dysplasia, indefinite for dysplasia, and also patients with non-dysplastic Barrett's who'd been referred to them. And the test impacted 55% of their management decisions. A high-risk result did lead to upstaging in a subset of those patients. So there were patients who, without the TissueCypher result, they would have just done surveillance on those patients. And the high-risk result was used as part of shared decision-making to support escalation of care to endoscopic eradication therapy. And another subset of patients had their decisions de-escalated due to a low-risk score by TissueCypher. And in the majority of those patients, there was an initial plan to treat those patients with radiofrequency ablation, and the low-risk score from TissueCypher supported a surveillance-only approach.
And then is there any ongoing discussion or potential for work of TissueCypher with some of the new experimental sort of AI-assisted imaging, esophageal imaging equipment and things that are out there in their developmental phase?
That's an interesting question. We have not done that yet, but that's something that may be explored.
Sure. And we got another question from Joe Chen. How many biopsies are needed to optimize, the TissueCypher result? So I can speak a little bit about commercially or what we offer. For a short segment patient, we require 1 biopsy for testing. And for a long segment patient, we request 3 levels, so a proximal, a medial, and a distal. And we will report out the highest scoring sample from those 3 to you as the test report. But can you speak a little bit to the concordance and some of the testing and published data that we have on the strength of this test in multiple biopsies?
So the spatial distribution of risk scores was reported in a paper from Cleveland Clinic and UPMC that performed a clinical validation on TissueCypher. And they showed minimal variation in risk scores between different endoscopic levels, which supported the recommendation to test a single level in short segment patients and up to 3 levels in patients with long segment Barrett's, as Jay described.
Thank you. So it looks like we've reached the half hour for our time, and it looks like we've gone through almost, I think, every question in the chat. I don't believe there was any that we didn't. We did have one more. So what role does AI play, in the TissueCypher testing, and is there, continuing evolution of the software, the platform with additional data?
AI methods were used in the development of the algorithms that detect Barrett's tissue on the sides and also identify tissue structures within those biopsies. We also used various AI methods to build the risk prediction algorithm that converts features into a risk score that's associated with risk of progression. While those methods were used in the development of the algorithms, once the test was selected in that training phase, all parameters were locked and then validated, and the clinical test is completely locked. There's no continuous learning through AI.
Thank you, Rebecca, and thank you all for joining us. That's all the time we've set aside for this evening. I believe we got through every question, but if you have a question you think of tomorrow or next week, certainly reach out to anyone at Castle. We would be happy to address your question. Lastly, I just want to say thanks again to all of you and have a good night.